Welcome to the Explainer. So, today we're looking at something that honestly challenges a lot of what we've all been taught about healthcare. I mean, we've all heard the phrase early detection saves lives, right? And for a massive portion of our lives, that is absolutely true. But there is a totally critical shift in how we actually need to view medical testing as we age, specifically after the age of 70. We're going to use the data and the medical literature to fundamentally rethink routine checkups. And I am so excited to guide you through this fascinating shift in perspective. Okay, let's dive into this. Picture this for a second. You're 74 years old. You feel great, you're sleeping well, your energy is fantastic, and you're just out there enjoying your life. You go in for a perfectly routine annual physical. You know that feeling, right? Sitting on that weird, crinkly exam table paper, your blood pressure already ticking up just a little bit just from being in the room. And your doctor says, let's just run a few tests, just to be safe. Well, 6 weeks later, you're sitting in a surgeon's office. Not because you actually had any symptoms, but because those just-to-be-safe tests found something. And treating that something set off a chain reaction that your 74-year-old body simply wasn't equipped to handle. Suddenly, your quiet, enjoyable life is completely upended. This happens way more often than the medical system likes to admit. To really wrap our heads around why this happens, we need to look through what we're going to call the longevity lens. Through this lens, the risk-to-benefit math of medical screening fundamentally changes over time. When you're 50, the math is incredibly clean. You find a problem early, you treat it, and you potentially buy yourself 30 more years of healthy life. Boom. But after 75, three huge things change. First, the conditions we find often grow so slowly that you'd likely outlive them anyway. Second, your body's tolerance for medical intervention drops. I mean, a surgery you might easily bounce back from at 55 can literally mean months of lost independence at 78. And third, it triggers something highly problematic. That specific problem is known as the cascade effect. It's like a row of dominoes, and it all starts with just one innocent scan. That routine test finds a tiny abnormality, maybe even a complete false alarm. But medicine doesn't like to just ignore an abnormal finding, so that automatically triggers a biopsy. Then the biopsy leads to a procedure, and the procedure causes a complication. Step by step, a person who walked into the clinic feeling totally fine is suddenly navigating a complete medical nightmare, and it was all triggered by a test they probably didn't even need in the first place. Moving on to Section 1, Rethinking Routine Colonoscopies. Let's get specific here and look at a real-world case. Take Dorothy. Dorothy is 77, 0 symptoms, absolutely no family history of colon cancer, and she'd previously had completely clean scopes. But she was told she was due for another one. So she drank that standard horrible liquid prep to clear her bowels, and it hit her kidneys incredibly hard. By the next morning, she was dizzy, confused, and severely dehydrated with dangerously low electrolytes. She actually ended up spending 4 days in the hospital just recovering from the preparation. And get this, she never even had the procedure. For older adults, just getting ready for the test can be exactly as dangerous as the test itself. And here's what the data actually says about this. The United States Preventative Services Task Force officially recommends against routine colonoscopies for average-risk adults over 75. Why? Because the risk of a bowel perforation, which is a literal tear in the colon, is about 1 in 500. In a younger person, okay, that's a manageable complication. But in a 77-year-old, that can mean an emergency colostomy bag for the rest of their life. The much safer, non-invasive alternatives are stool-based tests, like Cologuard or annual FIT tests. They can flag genuine warnings without ever putting you under anesthesia or risking a bowel tear. Section 2, Cancer and Heart Screens. Let's see how this applies there. Now, what's really interesting about this slide is an incredibly important concept we need to grasp called overdiagnosis. When we hear diagnosis, we naturally assume it's a good thing. We caught it. But our imaging technology today is so incredibly sensitive that it constantly finds cancers that are biologically asleep. These are tiny, super slow-growing tumors that, if left completely alone, would literally never spread, never cause a symptom, and never shorten your life. You would simply die with them, not from them. But the moment a scan spots them, the clinical machine just turns on, triggering intense, entirely unnecessary treatment. Take Richard, for example. He's a 79-year-old active, highly independent guy. He gets a routine PSA test that shows elevated levels. So he gets a biopsy, which confirms a slow-moving prostate cancer, and that leads straight to radiation therapy. The end result? Chronic fatigue, severe urinary problems, and a massive drop in his daily quality of life, all to treat a cancer he almost certainly would have peacefully lived alongside for the rest of his life. We see this exact same overdiagnosis problem with routine mammograms in women over 70 too, where clinically insignificant findings lead to brutal treatments that offer zero survival benefit, just terrible side effects. Now, let's switch gears and talk about your heart. Your doctor might easily say, hey, let's put you on a treadmill for a routine stress test, just to make sure your heart is okay. But here is the massive red flag. Up to 40%. That is the false positive rate for cardiac stress tests in certain populations of people without any symptoms. Nearly half the time, the test flags a major problem when your heart is actually totally fine. And that false alarm, it launches you right back into that dangerous cascade effect we were just talking about. Let's trace out exactly how this cascade happens. The false alarm leads to a cardiac catheterization, meaning they thread a tube right into your heart, which carries real risks of bleeding or arrhythmias. That test might find a partial, stable blockage, leading to a stent and lifelong blood thinners. But here's the kicker. The landmark ischemia trial proved that stenting stable coronary disease does not reduce heart attacks or extend your life any more than medication and lifestyle management alone. No way, right? The far better investment of your time and energy is simply optimizing your blood pressure, your cholesterol, getting good sleep, and literally just taking a 30-minute daily walk. Section 3. Bone and artery scans. Moving right along, let's look at routine bone density DEXA scans. Now, obviously, bone loss with age is very real, but the issue here is the automatic pipeline that follows. You get a DEXA scan, it shows low density, and you are automatically prescribed long-term bisphosphonate medications. But what often goes completely unmentioned in the doctor's office are the rare but absolutely devastating risks of being on these drugs long-term. We're talking about spontaneous, atypical fractures of the thigh bone, literally the exact bone you are actively trying to protect. They can also cause osteonecrosis of the jaw, which is this incredibly painful deterioration of the jawbone. And this brilliantly illustrates where we should actually be focusing our efforts. Because when you compare routine DEXA scans and automatic medication against practical, everyday lifestyle interventions, the results are staggering. Studies show that balance training, specifically Tai Chi, reduces your fall risk by nearly 50%. Just preventing the fall in the first place with balance training, throwing up some grab bars in the bathroom, checking your vision, and making sure you're getting enough vitamin D is statistically far more effective at preventing fractures than just handing an active 74-year-old a pill. And our final test to reconsider today is the asymptomatic carotid artery ultrasound, which is where they check the blood vessels in your neck. If they find a stable, totally silent blockage that isn't actually causing you any symptoms at all, a well-meaning surgeon might recommend clearing it out. But here's the shocking reality. The surgery itself carries a 2 to 3% risk of causing a stroke during or right after the procedure. You could literally trigger the exact catastrophic event you were going under the knife to prevent.
Section 4, your 5-question protocol.
So how in the world do we navigate all of this? Well, here is your script. Take your power back. Question number 1. What is the false positive rate of this test in people my age? You absolutely must ask this because it tells you your immediate risk of triggering that cascade effect. It tells you exactly how likely the test is to send you down a total rabbit hole of unnecessary, stressful, and risky follow-up procedures when there's actually nothing wrong with you. Let's move to and see how this builds. Question 2. If this test finds something, what are the realistic treatment options for someone my age and health status? This question is absolute magic. Why? Because it forces your doctor to pivot the conversation away from just generating findings and pushes them to focus on actual outcomes. It makes them stop looking at you as a generic patient and start considering your specific body and your true quality of life. Question 3. What is the procedural risk of any treatment we'd likely pursue? Honestly, this is the question almost nobody thinks to ask, but you absolutely have to. Every single procedure in medicine, from a tiny biopsy to a major stent, carries a risk. Period. You have the fundamental absolute right to know exactly what those risks are up front before you agree to step onto that treadmill or slide into that scanner. Question 4. What happens if we monitor this instead of treating it? In modern medicine, there is just massive, intense pressure to do something. But for many conditions found in older adults, watchful waiting is a highly legitimate and often vastly superior option. It requires a lot of courage from both the doctor and the patient, sure, but doing less sometimes takes way more wisdom than doing more.
So the crucial point is really summarized in question 5. What is the most effective, non-invasive intervention for this condition? Because as we've explored today, whether we're talking about heart health, bone health, or stroke prevention, lifestyle optimizations very often outperform surgical interventions, and they come with absolutely zero side effects.
I want to leave you with this incredibly powerful thought to mull over. There is a profound difference between medicine that simply finds things and medicine that actually helps you live well. After 70, your ultimate goal shouldn't be to generate a giant checklist of clinical findings. It should be to protect your independence and your ability to do what you love every single day. So the next time a doctor says, hey, let's just run a few tests to be safe, will you automatically roll up your sleeve, or will you use your 5 questions to protect your quality of life? Let me know what you think.